Dr. Upadashi, you can start the meeting.
Yes, sir. Warm good evening to everyone who have gathered here for this webinar. On behalf of Society of Fetal Medicine Telangana chapter, I welcome you all to this monthly online meeting. Previously, our webinar was on Fetal Face Part 1, which was about the imaging aspect. Today, it will be about Fetal Face Part 2, genetic testing for fetal anomalies, facial anomalies. So we'll have two sessions today, which will be a combined case presentation with panel discussion. I welcome you all. Today's moderator will be Dr. Shagun Agarwal ma'am for two sessions, and the panelists will be, they don't need any prior introduction. They're all pioneers and in the field of fetal medicine. I welcome Dr. Ashok Khurana sir, Dr. Chinmay ma'am, Dr. Ashwin Dalal sir, and Dr. Parvati ma'am.
Dr.
Praveen sir is also there. He's
Sure.
a mentor in SFM Telangana.
No problem.
Praveen sir also.
Go ahead.
Yes. So, are you able to see my screen, ma'am?
Yes, we can see.
Please go ahead.
Yes.
I think you please introduce Dr. Gayatri and Dr. Neelam, who are our speakers.
Sure, ma'am. Dr. Gayatri ma'am has done her DBO DNB and DNB Medical Genetics from Nizam's Institute, and she is the recipient of gold medal for medical genetics, and she is currently the consultant medical genetics department Fernandez Foundation, and she has number of publications to her name, and she's the author of 2 books, and she's an active member of SAMG and SFM. Welcome, ma'am. And I also welcome Dr. Neelam Saini ma'am, who is third year resident from Medical Genetics Department, Nizam's Institute of Medical Genetics, Nizam's Institute of Medical Sciences. And I welcome Ashwin Dalal sir, who will be one of the panelists for our discussion today. And he is the head diagnostic division, Center for DNA Fingerprinting and Diagnostics, Hyderabad, India. And he's also the adjunct visiting professor, Kasturba Medical College, Manipal. He has 121 publications to his name, and I extend my warm welcome to you, sir. And I also welcome Dr. Shagun Agarwal, ma'am. She's the additional professor, Department of Medical Genetics, Nizam's Institute of Medical Sciences, and she's also the adjunct scientist for CDFD Hyderabad. And she has number of publications to her name, index publication almost 50. And her research interests include genetic characterization of fetal malformation syndromes. I welcome you, ma'am. And I welcome Professor Dr. Ashok Khurana, sir. He doesn't need an introduction. He's MBBS and MD he did in All India Institute of Medical Sciences, and he's trained at the Herlev Hospital, Denmark in ultrasound. He is the past president of the Society of Fetal Medicine and editor-in-chief for the Journal of Fetal Medicine. Welcome, sir. I also welcome Professor Dr. Parvati ma'am. She's also from our Nizam's Institute of Medical Sciences, Department of Plastic Surgery. And she's the recipient of, she has been a visiting fellow of the Changgang Memorial Hospital and director of the Smile Train Cleft project. I welcome you, ma'am. And I also welcome TLN Praveen, sir. And each and every budding fetal medicine expert in Hyderabad will know him. He has been practicing fetal medicine for the past 30 years. And he is passionate about looking at the fetus and performing invasive procedures. And his hobbies include running and hiking. And he has been the recipient of number of awards. He has received certificate of excellence for the first coronary angioplasty in the country. And he has number of publications to his name. And he's also a reviewer for American Journal of Sonography and Journal of Fetal Medicine. I welcome you, sir.
Thank you, Dr. Rupa. I think we'll go on to Dr. Chinmay's welcome address. So
yes,
Dr. Chinmay does a very good introduction. She's the glue who keeps us together in the Telangana chapter.
Yeah, I'm indeed a very, very sticky person. That I completely agree. So at the outset, thank you, Dr. Shagun, for making this program a reality. We've already welcomed all our seniors here, and it's really a nice platform to discuss some topics which come to our clinics as day-to-day problems. But once you start looking at it in detail, you realize there are so many aspects to it. So just the fetal phase, we discussed in the last meeting about the structural evaluation of the face, two-dimensional, three-dimensional, from this aspect, from that aspect. And now we have realized that just diagnosing a facial anomaly is not enough. There is this whole brigade of genetics which comes to the, it opens more questions actually than it answers, is what we feel as lay clinicians. But with these experts around, Dr. Ashwin has been a stalwart in genetics here, and really one of the persons who how can I say that he's done hand holding for all obstetricians here in Hyderabad for the past 2 decades. And that's how, genetics has evolved here in Hyderabad. Dr. Parvati is a stalwart in her field. And I must put on record that, it's been such a pleasure working with her. Even our patients, when we send to her for antenatal counseling and, taking care postnatally, it has been a really, really rewarding experience. So with all these people on board, let's not waste any more time and get straight onto the job. So thank you very much. And the first topic, I think, is on the cyclops and its microforms by Dr. Neelam Saini. So Dr. Shagun, over to you.
Yeah, thank you, Dr. Chinmay. So we are going to have 2 sessions today. So the first session is going to focus on the upper part of the face, and then the second one on the lower part. So the upper part of the face, we are going to first discuss the orbital abnormality. And the most severe orbital abnormality we come across is cyclops. And then there are certain minor forms of cyclops which also we should be aware of. So Dr. Neelam, you can make it full screen. So we'll go through some cases and then we will have a discussion regarding that particular finding. Dr. Neelam, you can start.
Ma'am, my full screen is visible now, ma'am. Good evening, all. So shall we start?
Good evening.
Yes.
Yes. So today's we have divided our session into 2 parts, part 1 and part 2. So in part 1, we will discuss upper face, and part 2, we will discuss lower face. In upper face also, we have divided into 3 parts. In part 1, I will be discussing about orbits, in that cyclops and its microforms. So here we have 2 cases. So this was the first family. They were non-consanguineously married couple, and they came to us at 17 weeks of gestation. Ultrasound findings suggestive of hypothyroidism. So here we can see hypothyroidism over the left lip and palate. And here we can see holoprosencephaly with monoventricle and fused thalami. So with these ultrasound findings, the prognosis was excellent, and couple decided to go for termination. After termination, fetal autopsy was done at
Dr. Neelam, your voice is dropping in between.
Yes, ma'am, I'm near my own. So with fetal autopsy was done. In the fetal autopsy, there was hypothyroidism. Here we can see left lip and palate. And here we can see the flat face, mid-face hypoplasia. And in the brain dissection, we can see the lobar holoprosencephaly. There was monoventricle, and the monoventricle was collapsed while opening the brain, and they were fused thalami. And so the further testing was done. So further testing, as we do, as rule out chromosomal anomalies in cases of holoprosencephaly. Amniotic fluid amniocentesis was done, and amniotic fluid karyotyping was done. That suggested total number of chromosomes 69, means triploidy. So here all chromosomes from 1 to 22 and X chromosome had 3 copies. So this condition is known as triploidy. So this was our first case. Then we have our second case.
Next slide, please, Neelam.
Yes,
so,
ma'am.
So just wait, Neelam. So just wait. So as Dr. Neelam has said, so here, this particular case, we had triploidy as the cause of the holoprosencephaly in this fetus. So in fact, whenever we see holoprosencephaly, the first thing we need to look for are chromosomal abnormalities. So around 40% of fetuses with holoprosencephaly would have a chromosomal abnormality, of which the most common is trisomy 13. But then triploidy also can be seen in certain cases, as we found here. And this is picked up on karyotype. So here I would like to just ask Dr. Ashwin once, whether like nowadays, because whenever there is a fetal malformations, usually chromosomal microarray is being preferred as the first direct test. So should we be doing that, or in these cases, should we be doing karyotype? So, or are there any other tests which would be useful to detect triploides and other polyploides?
Yeah, so microarray is more of a comparative test. So it compares the amount of genetic material between a supposed normal and your patient. So when there are ploidy changes, everything increases equally throughout the chromosomes. So microarray, there may be a problem to detect the triploides, and that's why here karyotype is the diagnostic test of choice to detect triploidy. Although microarray is regarded as a better test to detect the small deletions and duplications throughout the genome, but for certain reasons like triploidy, here karyotype would be a better test to detect the abnormal chromosomes.
And what about in like maybe in cases of like where there is a clear-cut aneuploidy like Down syndrome or some other aneuploidy? There also, is there any relevance of doing a parallel karyotype? Does it help in any way? Like,
So karyotype, the advantage of karyotype over microarray would be the detection of any of the balanced chromosomal rearrangements, which would not be any again detected on the microarray. So that is something additional on karyotype that you tend to get. So other than that, microarray would be more useful in terms of, but if you are suspecting a clear-cut trisomy 21 or something based on your initial screening tests or something, then karyotype is a better test since it's a cheaper test for the patient. So you would have to take the decision based on the situation. If you are doing prenatal diagnosis for a uh, screening test positive or something, and if there is a problem with the economy from the patient side, then karyotype seems like a better test. But otherwise, microarray would detect all the things that are detected on a karyotype except balanced translocations and triploides, these kind of abnormalities.
and I think even probably as you said, so because of those rearrangements, so suppose sometimes some kind of aneuploidies may also be part of a rearrangement, so that may change a recurrence risk for the family. So probably it's a good, I mean, good kind of practice to do both the things ideally, so that you get a complete picture.
Yeah, so that is commonly what we see in Down syndrome due to a 1421 or a 1321 translocation. So there, again, the risk changes from less than 1% for a free trisomy compared to that will have a 5 to 15% risk for the translocations. So that's the additional information that you get in karyotype as opposed to a array. So if possible, doing both is really helpful. And since karyotype is not that expensive in our country, if you're doing a microarray and additional karyotype, that would be the ideal thing to do.
Thank you, Dr. Ashwin. So, like we see how, despite the availability of advanced technologies, sometimes a basic karyotype can also give us certain information, and some things like all these triploides, tetraploides, and all would actually be better picked up in a karyotype rather than array. So, it's important to choose the correct test also. So now we'll go on to the second case, and then let's see that besides these, are there any other tests which need to be done in certain scenarios?
So this was our second case. Here the couple is second degree consanguineously married, And this was the first pregnancy, and the FIFA scan suggested holoprosencephaly. And the findings we can see in the antenatal scan are, here we can see the abnormal and here we can see the absent nasal tip, and here we can see partly fused orbits, and here holoprosencephaly finding, that is oil over holoprosencephaly, monoventricle and fused thalamides were there. With proper genetic counseling, they decided to terminate the pregnancy, and amniocentesis was also done before termination. So after termination,
Your audio is again dropping, Dr. Neelam.
so after termination of the pregnancy, the fetus was brought for fetal autopsy. So here in autopsy findings, we can see the cyclops and the absent nose. And here the facial profile can be seen as concave face, and then brain dissection showed fused thalami that confirmed the findings of lobar holoprosencephaly. Amniotic fluid DNA chromosomal microarray was done, and that was normal. And after that, whole exome sequencing was done for that pregnancy. It was inconclusive, or we did not find any conclusion from whole exome sequencing. Subsequently, the second pregnancy also happened.
No, I think
Findings were also there in the second pregnancy.
I think it's very
Audio problem
audio
there.
is very poor. I think, are you talking into the computer?
Yes.
But then how is it that maybe this the bandwidth is poor because we are not able to hear you.
Yeah, actually, every time you start using the pointer, your voice disappears. I think you're changing direction.
Yes, ma'am.
Interfere with the quality of final production. So if you could please speak into your mic at all times.
You could otherwise sign into your another device and keep the computer mute and speak through that.
Yes, ma'am. One second.
Yes, now the sound is right. Yeah.
Now, sir, it's okay.
Yes.
Yeah.
So we were discussing that second pregnancy. In the first, this was second degree consanguineous couple. They came with abnormal TIFA scan at 20 weeks of gestation, and when scan was done, there was abnormal, this facial profile, absent nasal tip, and partly fused orbits were there. And in the brain findings, they were L over holoprosencephaly. And then the proper counseling, couple decided to terminate the pregnancy. And then after termination, before termination, amniocentesis was also done, and amniotic fluid sample was sent for chromosomal microarray. In autopsy findings, we can see here the cyclops and the absent nodes. There was concave facial profile, and then we can see fused thalami that are also in favor of L over holoprosencephaly. So all scan findings were confirmed in autopsy, and then the genetic report came. Here the chromosomal microarray was normal, and whole exome sequencing was done. That was also normal. Subsequently, second pregnancy also happened, and the couple, the same findings were also there in the second pregnancy. Scan findings and autopsy finding in the second pregnancy of the second degree consanguineous couple also suggested L over holoprosencephaly. And then again, whole exome sequencing was done for the second baby, second fetal DNA, and that also normal. So here whole exome sequencing for both the fetuses were normal. So now we are planning for whole genome sequencing.
So yeah, so after the second case, before I ask my panelists the question, so I'll just give a brief, information about holoprosencephaly. Of course, all of you are aware that holoprosencephaly is a problem involving division of the embryonic forebrain, or what's also called as prosencephalon, and we are all aware that there are different spectrum of severity of holoprosencephaly, A lobar being the most severe and the lobar being the mildest form. And these basically represent the degree of fusion which is there between the cerebral hemispheres. And most of them are equally equally proportionately divided, except the very rare middle hemispheric variant type.
No, I think you're.
Sorry, I was not audible.
Yes. Now you are audible.
Oh, okay. I'm so sorry. Yeah. This, everybody here would be aware of. So we have the various types of holoprosencephaly ranging from the most severe A lobar to the mildest lobar type. And most of them are almost equally common except with the middle hemispheric variant type, which is quite rare. Then in this case, we have chromosomal abnormalities, as we saw earlier. These are the commonest types, so which would be picked up by doing a simple karyotype. Whereas in a 10 to 25% cases, various different types of copy number abnormalities can be there in holoprosencephaly, involving various different chromosomes. And then we also have single gene disorders, again in around 10 to 25% cases of holoprosencephaly. And actually, these are more interesting because here the recurrence risk is going to be pretty high. And in fact, a huge proportion of these families would have one parent who is also having the same genetic mutation. But the parent, in fact, has a very mild form, or even sometimes the parent may be completely healthy, but the parent is having the same mutation, and now the baby has, it's an autosomal dominant inheritance, so the fetus carries the same mutation, but the fetus is more severely affected. So, in fact, this is a very commonly known phenomena in holoprosencephaly. It shows incomplete penetrance, that is, not everybody with the mutation has holoprosencephaly, and it also shows variable expressivity, whereby in the same family with the same mutation, somebody may be having lobar holoprosencephaly and somebody may be having a lobar holoprosencephaly. So these forms are actually, these single gene forms are important to pick up, because these will recur and recur with the tune of 50%, because one of the parent carries a mutation. Whereas the chromosomal and the copy number abnormality, these are the ones where the recurrence risk is pretty low, around 1%. And then rarely holoprosencephaly can be part of certain syndromes also. And then there are, of course, certain teratogenic exposure, and in certain cases, the etiology does remain unknown, and various multifactorial origogenic causes. So, so if we see, there is another very important dictum in holoprosencephaly, which is called the face predicts the brain. So basically, the more severe the brain abnormality, the more severe you'll have the facial features. So like we saw in the fetuses just now, so we had the alobar holoprosencephaly and the face had cyclops. As we move on to the milder forms, we see relatively minor abnormalities in face. So here we are seeing just a midline cleft and hypotelorism, that is more closely placed eyes. This child who has lobar holoprosencephaly has closely placed eyes and very closely placed nostrils. And this lady who has this middle hemispheric type has only one finding, and which you can see here in the teeth. This is the basically single incisor. So instead of having two upper incisors, this lady has only one incisor. So it's important why I'm telling this is because, as I said, sometimes the mutation is inherited from a parent. So we need to take a look at the parent to look for such minor findings, because these are the findings which will give you a clue that this is holoprosencephaly, which will happen again in this family. Next slide. So next slide, Neelam. So these are the basically the minor forms, or we can also call them the microforms. So these are little difficult to diagnose prenatally. And when should we think of holoprosencephaly, or what kind of facial clues or facial microforms should alert us that, okay, this baby, we need to take a closer look at the brain. So whenever the fetus face is showing hypotelorism, or there is a cleft, especially a midline cleft, and if there is a flat face, a flat nose, single nostril, or arrhynia, these are some of the facial findings which should alert you to look at a closer to look closely at the baby's brain, and to see whether there are any minor forms of holoprosencephaly which you are missing. And then, of course, we all know this, an absent CSP is again a red alert, and of course a positive family history. And then again, in every fetus with suspected holoprosencephaly, examination of parents is very important to look at these microforms, because this changes the recurrence risk to 50%. Always a 3-generation family pedigree tells us some clues, like there could be history of intellectual disability, seizures in some family member whose MRI has never been done, and you don't even know that person has holoprosencephaly. So whenever a fetus has holoprosencephaly, we need to look at these important additional findings. So next slide. So whenever a fetus has holoprosencephaly, of course, you do a detailed ultrasound, you look for additional abnormality, you look at the degree of holoprosencephaly. because that's going to decide your prognosis to a large extent. And the testing should include first karyotyping, and then in addition microarray, and of course exome sequencing also should be done, because we saw 10 to 25% cases have single gene disorders which will not get picked up on karyotype on microarray. And probably fetal MRI could be done to look for the minor forms. And the prognosis for the severe forms is, of course, very poor. For the milder forms, they may survive, but they usually have some. For the monogenic forms, is 25 to 50%. So now I think I will stop here and I will ask my panelists. So my first question would be to Dr. Praveen. Praveen sir, I just wanted to know, like for these minor forms of holoprosencephaly, like how easy are they to pick up? Or I mean, can they be picked up by sonogram, or do we need to do an MRI?
Thanks, Sagun. I think you have told everything. I think the panelists need not talk anything at all, because the whole thing has been put forward. Anyway, basically, I mean, the minor forms and the major forms, I mean, nothing like that. In the sense, we don't follow that sort of categorization. Basically, we have the severity score. That is what is more important. And we take the severity score, we know that, see, basically it is a cleavage abnormality. Frontal, that is the prosencephalon, is the one which does not cleave. And that is the reason why there is cyclops and all those facial abnormalities also associated with it. The lobar and alobar are the ones which are severe forms, wherein what we have is that frontal lobe will never cleave. In alobar, we have the whole brain not being cleaved, whereas in a lobar, we may have the occipital region being cleaved. Whereas in the middle variety, what we have is the semi-lobar. We have extending up to the mid portion, but then the frontal region still remains uncleaved. Whereas there is another thing is the middle intermittent variant, wherein you have this semi-lobar as well as the middle intermittent interhemispheric variant are the two things which are minor. In the sense, you need to look for other features. And MRI basically is not really not going to, because see, quite often the alobar holoprosencephaly or the severe forms are very well diagnosed in the early phases of the pregnancy, that is in the first trimester itself. So we don't go into the second and third trimester. I mean, MRI will be asked only when you go in for late second or third trimester. And in that situation, yes, there is what is called as the score, which is called as Mayer score, which MRI scores based on the severity of the unfused cerebral hemispheres. So they have given a score. I mean, of course, I have never used it before. The only thing is, very rarely we really ask for it. Quite often what happens is sometimes when they miss in the first trimester, naturally these milder forms are missed in the first trimester. So they are picked up in the second trimester. Quite often, most of the times the outcomes which I have seen, and only one case was there where there was the middle interhemispheric variant, which was absolutely normal in the postnatal period. The other one, which was a semi-lobar, I could not follow them. They did not turn back. So I have no clue. So anyway, minor forms are the ones which are not having much of a cleavage abnormality. When the cleavage is severe, we call it as major. When the cleavage is minimal, then we call it as minor. So that should be the differentiating feature. Minor are definitely difficult to diagnose in the first early phases of pregnancy. And the late mid-trimester, we try to evaluate them and try to diagnose them.
Yeah, thank you, sir. I think, so as you said, sir, so the minor forms a little tricky, and like we may not be able to kind of pick them up till later in pregnancy. But then on the other hand, as you said, like some of them would probably maybe normal also eventually postnatally. They may not really have significant handicaps. So that's why in holoprosencephaly, actually counseling becomes, especially for these minor forms, counseling is a bit tricky because the prognosis is not always 100% certain. So that's there. So I think the severe forms are the one where we really can kind of immediately come to a diagnosis and prognosticate the family also. So I would like to ask Dr. Chinmay, Dr. Chinmay, then the severe forms, like, can they be confused with any other abnormalities, brain abnormalities, or most of the times they are easy to diagnose on ultrasound alone?
Oh, well, brain abnormalities are never easy to diagnose. It's easy to say whether the brain is looking normal or abnormal, actually. But when you see an abnormal brain, then you'll always have to think of the differential diagnosis. Now, the thing is, if you see in the first trimester, like somewhere around the NT scan, if you see that the choroid plexus is not looking like the normal butterfly appearance and the front of the brain looks like anechoic semicircular area there, then diagnosing holoprosencephaly in the first trimester is actually easy. When it comes to second trimester, definitely you can say that there is a problem, and it looks like a very, very severe problem because the brain architecture is completely disorganized when you see this. But we can be confused sometimes because here there is an incomplete cleavage. So you see a sort of merging of both the sides of the brain in the center. But suppose you have very severe hydrocephalus, like very, very severe ventriculomegaly, then also you can get confused because you don't see the margin sometimes very clearly. And if it's an asymmetrical thing pushing the fox to one side, you may not be able to distinguish it in the very first look of it. So if you look at the textbook descriptions, hydranencephaly, where you don't see the cerebral mantle at all, or severe hydrocephalus, can be a differential diagnosis if you have not looked at everything in detail. It's not, you know, a lot of experts will say why you should not get confused, but it is possible to get confused if you have previous pictures. For example, if there is a first trimester picture of a beautiful butterfly sign at that point, then it becomes easier to say that this is unlikely to be holoprosencephaly, but a form of one of these ventricular dilatations which has occurred in a serial manner and distorted the brain anatomy. Even things like, you know, absence of the cavum septum pellucidum can lead to confusions of like at least semilobar types of holoprosencephaly. So septal agenesis, hydranencephaly, severe hydrocephalus, these are the things which some of us could get confused. At least I can get confused. Dr. Shagun, you're muted here.
Yeah. Yeah, thanks so much. So in these cases, I think invariably the couple would usually go for a termination. So I think an autopsy would help us probably
Exactly.
to
I mean, it's not
differentiate.
usually a clinical problem as such because the prognosis is so bad. But if you really want to distinguish, I think a stepwise approach of looking at every part correctly, trying and seeing the cerebral mantle, looking at the arteries and veins, checking the posterior fossa, you know, everything. If you start doing the brain, look at every part and complete your checklist, you're more likely to reach a correct diagnosis.
Correct diagnosis, yeah. And hopefully like the autopsy or an examination after birth would help us.
The problem with autopsy is, Dr. Shagun, you know, unless somebody like you who handles the specimen right from the time that it is expelled and takes care of the brain, then it's easier. But otherwise, if the samples are transported over long distances without the brain being fixed properly, more often than not, the autopsy reports say brain is autolyzed.
Yeah, that's true.
So that is a practical problem which all clinicians have faced with regard to autopsy of the brain. I mean, some of you experts really know how to fix the brain, and how much ever we tell people that they can put in a little bit of formalin through the fontanelles, I don't think that really happens. And the brain doesn't, we don't get intact brain specimens on autopsy that easily.
So would you think, I mean, in such cases, I mean, an MRI would help us, I mean, antenatally, or maybe after birth also, you know, like even if the autopsy is not done, if some, you know, can get an MRI done, would that help in?
As a clinician, we always look up to the MRI to give us something more than what the ultrasound can provide. But I'll let Praveen sir answer that because he has got, you know, technical expertise on whether that's really a sensible approach or not.
I mean, I would not ask for an MRI. The reason is that first trimester, see, most of these severe forms are definitely diagnosed in the first trimester. There is no second thought about it. Only the milder forms are the ones which will create problem. Wherein you, well, anyway, when you progress on to the late second trimester, you definitely do a thorough evaluation of the fetal brain through neurosonography, wherein quite often you get the information required. Very rarely you may have a problem where particularly the semi-lobar, you may have a doubt, but then normally no. I mean, we don't really ask. But then when we want to grade the severity, yes, we do have to. But that depends upon the patients. In the sense, when you counsel them and say them that this is a problem, which is a brain problem, which is associated with some severe disability, neurodevelopmental abnormalities. In case if they want to continue, then definitely they will agree for MRI. If they don't want to continue MRI, they won't agree. I mean, this is.
Please allow me to ask a very stupid baseline layperson question. Now, we know two things. One is that it's a severe abnormality. They may not continue. That part is okay. But what genetics will you do with it? They have different sets of genes for different kinds of brain abnormalities that the geneticist will tell us. We also know that the autopsy itself is not practically always an answer because the brain gets autolyzed. In that condition, sir, do you think, suppose we leave the finances and everything aside, do you think it would make sense to do an MRI prior to termination to characterize the brain as much as possible so that the geneticist could take a better decision? Or because whole exome sequencing is available, whole genome is available, the geneticist does not need to know that, and anyway you'll do the umbrella test.
I think scientifically, yes, we need to do. Definitely, once the patient is agreeable, when you have a milder forms where the patient is not willing to continue, asking them to get an MRI, I think it's very reasonable. I mean, it's definitely going to open up certain important aspects, particularly to score the severity. Once you score the severity, at least you're confident in what you have diagnosed. So I mean, that definitely we have to ask for it.
So Dr. Shagun, would you like to have that done prior to a termination?
Yes.
Rather than an autopsy?
Rather than an autopsy, no. I think both. I mean, I would like both. So that's what. So as you rightly put, so for us, it's very important to actually have the correct morphological diagnosis to be able to, one thing, order the correct genetic test, and second thing, to also interpret the test correctly. Because the etiology for holoprosencephaly or the genes involved in holoprosencephaly will be very different from those involved in
Hydrocephalus
hydrocephalus or sometimes even hydrancephaly. In fact, hydrancephaly mostly is disruptive. It's not even genetic, but there are some rare genetic forms also. So to make the correct morphological diagnosis really helps us to do the correct test and to interpret the test. So, I mean,
but
if sir says, I mean, if you feel that an MRI would help us, if there is a confusion and it gives us clarity.
But then if I do an IUMR and then give you a specific morphological abnormality, where is the need for an autopsy?
Sir, autopsy has additional this thing because it will give us a lot of other clues like certain dysmorphisms and
so maybe not for the brain alone. I mean, the autopsy for the whole other individual aspects of
that. Anyway, you are going to see by IUMRI or by ultrasound.
So those low set ears.
Yes, sir. The dysmorphism, sir. In fact, it's for us geneticists, that is a very important aspect. Because
you want
we make a diagnosis on just looking at the face of the baby sometimes. So
high-arched palate, low set ears.
Yes. So I would still want an autopsy before we go for the genetic test.
Yeah, that's your call.
Okay, yeah. So thank you, everybody. I think so. The message from this is that, like most forms of holoprosencephaly, the severe ones would be not missed, diagnosed as early as first trimester, and then certain minor forms, especially for prognostication, you would need to probably do an MRI. But then a genetic testing is very important for all the cases, and this should involve a comprehensive testing, including karyotype array and exome as needed as per the particular situation, the family, the diagnosticating this pregnancy. We are also able to give a proper counseling to the couple for their subsequent pregnancies. So I think probably with this, we can move on to our next topic.
Shagun, I have one question for you. What is the C-DON?
I didn't get it, sir.
C-DON.
C-DON?
Yep.
I don't know. So what
it is supposed to be a cell surface receptor. regulated
gene-
skeletal
yeah.
myogenesis.
There is a gene called as CDON. I mean, that is what I know, and I
And
think
results in
that
the
is
facial
also
defects. It seems mutation in the CDON results in facial defects. I mean, I just wanted to know your experience in this because I have never heard this.
no, sir. I mean, this is one of the many genes. I don't recollect immediately whether CDON mutations cause a specific phenotype, but I think it is somewhat related to some facial abnormalities and probably some brain abnormalities also. But I would have to check and get back to you on the exact phenotype.
Yeah. Okay.
So I think we'll move on to the next topic. Dr. Gayatri is going to tell us about one of the very kind of common scan findings, which is not really an abnormality, but a soft marker. Dr. Gayatri will be.
But a real troubleshooter.
Dr. Gayatri, yeah, you can share your slide.
Yes, sir. Yes, ma'am.
Ashok, any comments? He's keeping quiet. I don't like to keep him quiet.
Well, you know, the point is that it's a question of not worrying about resources anymore. There is just too much at stake to think whether we should do one or the other. We know that this is an evolving science. We know we won't have all the answers, even if we do all the tests. But at least let's just get all the tests going. And what I think is the answer to this complete business of not getting to the right answer is the fact that just about everybody who's involved in fetal healthcare today, from an industry point of view, is willing to do free testing for us, provided we give them a certain number of tests. We keep up a momentum because that keeps the lab going. So if we can do that and remain in a bargaining position that, look, I send you double markers all the time, and could you please do this genetic evaluation for me? Wonderful. Or the same labs have now started doing autopsies, and we say, okay. And for MRI, of course, I just use relatives and friends all the time. I'm sure that within the next 3 years, we will have many more answers than what we're producing today. So let's try and use our great Indian methods of overcoming this problem rather than the fact that, okay, let's try and raise resources. All these companies are willing to come to our rescue. I think we now are 4,000 strong at the Society of Fetal Medicine, and we have a presence and we can demand what we want. And they're only too happy to help out because they have a good sense of social responsibility.
So the commercials are also answered.
Completely.
Go ahead. I think Gayatri, please go ahead. Sorry.
Yeah, no problem, sir. Good evening, one and all. I thank SFM for giving me the opportunity. So the topic is regarding hypoplastic and aplastic nasal bone, Down syndrome, and more. So if you come to the introduction, like we know that nasal bone length measurement has become a routine prenatal care both in first and second trimester. So all of us know that nasal bone hypoplasia and aplasia are associated with common chromosomal aneuploidies, specifically trisomy 21. So, but in addition to these common chromosomal aneuploidies, there are cases with isolated nasal bone, hypoplastic nasal bone, which are associated with the copy number variations. So we'll come to the case scenarios. The case one, this is a case of non-consanguineous couple. Their first pregnancy has resulted in spontaneous abortion. In the second pregnancy, there was hypoplasia of the nasal bone. In the second pregnancy, it was a spontaneous conception. NT scan, nasal bone could not be visualized, but first trimester screen was low risk for common chromosomal aneuploidies. Scan at 16 weeks has shown hypoplasia of the nasal bone. So pre-test counseling was done for the couple, and they have been given options of amniocentesis, fetal karyotype, and microarray. So the couple opted for amniocentesis and chromosomal microarray. Microarray has revealed 2.7 MB heterozygous pathogenic deletion of chromosome 2q37.3. So as we all know that each chromosome has P arm and Q arm. In the Q arm, in 2q37 band, it has three regions: 2q37.1, 0.2, and 0.3. And this 2q37.3 is the region which is deleted in this particular fetus. And this region has COL6A3 and HDAC4 genes, which are significantly influencing the phenotype of the fetus or the child post-delivery. So when we look into the syndromic features of this particular 2Q27.3 deletion syndrome, these children after birth present with hypotonia, feeding difficulty, and respiratory distress. Some of them can have facial dysmorphism, and later on during the developmental delay and intellectual disability can be seen. And some of them can present with short stature and brachydactyly. Obesity is also known to occur. Some of them presented with autism and behavioral abnormalities with this particular syndrome. So coming to the facial dysmorphism in this particular syndrome, the typical features will be like prominent forehead, arched eyebrows, and eyes will be deep set with narrow palpebral fissures, T-shaped tip of nose, flat philtrum, thin upper lip, and the face will be round with full cheeks. These typical facial features may not be present in all the children, but they can be present in most of them. And specifically in those cases who have very smaller deletions may not present with these typical facial features. So on follow-up, the couple terminated pregnancy based on the counseling, and the karyotype of the couple which was advised during the counseling was normal. Both the couple karyotype was normal. So the couple were told that this is a de novo delusion which is not inherited from the parents, and they have been told that the recurrence risk is not more than 1%, and prenatal testing is possible in subsequent pregnancies. So if you look into the case 2, this is also again a non-consanguineous couple. They had first child who was 5 years old, male child who is completely normal. And in the second pregnancy, there was unossified nasal bone. They have terminated. And this is the third pregnancy, and she is at 34 weeks at present. So in the second pregnancy, it was again a spontaneous conception. NT scan, nasal bone could not be visualized, and low risk for trisomy 13, 18, 21 in the serum screen. Scan at 16 weeks has shown that the nasal bone is not ossified or aplastic nasal bone. Again, pre-test counseling has been done. Amniocentesis and chromosomal microarray was opted by the couple, and chromosomal microarray of the fetus has revealed heterozygous deletion of again 1 MB on chromosome 3q26.1 and q26.2. So this is the this red line is a deletion which is seen in the fetus. And if you look into the databases, like we can see that this is the deletion which is the fetal deletion, and the deletion which was smaller than this, the red one, these children were found to have global developmental delay and seizures. So specifically in this particular region, the gene TDCD10 and SERPIN1 gene are the genes which are responsible for this particular phenotype. Though many genes will be present, some of the genes will be very intolerant, and then this phenotype of this particular fetuses will be due to those particular genes. So when we look into the features of this particular 3q26.1 to 6.2 deletion, these children usually present with global developmental delay. Maybe they might be normal initially at birth if they don't have any malformations. Later on, we see that there is a global developmental delay. Some of them have focal neurological deficits. Encephalopathy is also been manifested in some of the children. Some of them may or may not have late onset seizures or epilepsy. So this couple also terminated pregnancy, and this couple were advised karyotype, and that was normal. Again, recurrence risk was not more than 1%. And in the present pregnancy, chromosomal microarray was opted by this couple from the amniocytes, and it was normal. She is 34 weeks at present. IFA scan was normal, and growth is normal at present, and the pregnancy is ongoing. So when we look into the case 3, this is a non-consanguineous couple. And they came in the first pregnancy, and at 16 weeks, there was hypoplasia of the nasal bone. This was again a spontaneous conception. NT scan, nasal bone could not be visualized. Serum screen has shown that there is a high risk for trisomy 21. Scan at 16 weeks showed that there is a hypoplasia of the nasal bone. So again, amniocentesis and microarray was opted, and then 2.8 MB heterozygous pathogenic duplication was seen in chromosome 22q11.21. If you look into this particular chromosome 22q11.21, this again has 3 regions, 21, 0.22 and 0.23. Out of these 3 regions in this particular band of 22q11, this particular 22q11.21 is a typical deletion which is mostly reported. And this deletion is usually ranges from 1 MB to 3 MB, and this fetus had 2.8 MB deletion. So when we look into the exact phenotype of this particular 22q11.21 duplication, as we have seen in the previous two cases where there was a particular phenotype in the fetus with the particular deletion, in these cases we have variable phenotype with incomplete penetrance. Some of them in the prenatal period will be completely normal without any anomalies, and some of them can present with fetal growth restriction, and this is the most common fetal abnormality which was seen with 22q11.21 duplication. And the phenotypes after birth may range from normal individual to a mild intellectual disability to severe intellectual disability. So it is very difficult to counsel this couple to predict the phenotype of the fetus postnatally and tell the couple. And these fetuses sometimes can have multiple malformations, including cardiac, GAT, and urogenital system. But if these abnormalities are not there, then it is again challenging for the geneticist to explain exactly the phenotype of the fetus. And some of these children were also found to have autism. So counseling has been done for them. Both karyotype and chromosomal microarray has been advised. In the previous two cases, we haven't advised the chromosomal microarray of the couple because most of all the cases which have that particular deletion will be abnormal. So both if the couple are normal, we need not do. But here in the case of 22q11.21 duplication, there are variable phenotypes. So we do microarray and karyotype of the couple, which was found to be normal. So it is again a de novo duplication. Again, recurrence risk was not more than 1%, but they were told that prenatal testing is possible. Since there was no certainty in the phenotype of the fetus, the couple continued the pregnancy, and they have delivered a male child, and the weight of the baby was 2.5 kg. And the child is 3 months at present. At present, the child's development is normal. So when we look into the either anossified hypoplastic nasal bone, we all know that it is a soft marker for the most chromosomal common aneuploidies like 21, 18, 13. Specifically for 21, if we take the positive likelihood ratio, it is almost 11 to 50. In addition, this isolated hypoplastic nasal bone has been reported in 5p deletion, 4p deletion, 1q, 8p, 10q, and xp. So some of the other chromosomal microdeletions were also reported in cases with isolated nasal bone hypoplasia or aplasia. So when we look into the literature search, like in a 2-year study, which was both prospective and retrospective study, which was done from 2018 to 2020, almost 55 cases were taken into consideration, which was done in Changhou Maternity Child Healthcare Hospital. In this study, they have found that in isolated cases of nasal bone hypoplasia or aplasia, the yield of CMA was 7.27%. And postnatally, 2 cases they have found to have a single gene etiology. So when they have included whole exome sequencing, it was coming to 16.67% yield in isolated hypoplastic nasal bone. In another study, like 6-year retrospective study, which was done from 2016 to 21, total of 5,742 cases were there, out of which 1,573 cases had undergone the invasive testing. In them, what they have done, this study was done in Medical University of Lodz, Poland, and all these cases were from the origin of Caucasians. And in these cases, out of 1,573 cases, they have found that some of them have undergone the invasive procedure. In that, they have excluded the cases who had common chromosomal aneuploidies 21, 18, 13 trisomy. And out of those, 60 cases were found to have anossified nasal bone, out of which some of them were isolated and some of them were associated with some soft markers and some of them were associated with multiple abnormalities. So based on this study, they have found that in isolated cases, the yield of CMA is 7.1%. In cases with other abnormalities or soft markers, the yield was 57%. So coming to the conclusion, nasal bone hypoplasia is a marker of facial dysmorphism. So in addition to common chromosomal aneuploidies, it is a marker for other copy number variations in chromosomes. So prenatal diagnosis by chromosomal microarray should be considered in cases with even isolated nasal bone absence or hypoplasia. It has been found that hypoplasia of the nasal bone was found to have more of a chromosomal abnormality when compared to nasal bone aplasia. So when the nasal bone hypoplasia has other abnormalities in the fetus, then we need to consider even whole exome sequencing. So by doing all these things, we can improve the clinical management of pregnancies, and also we can help the couple to make appropriate reproductive decisions. So these were the references which I have taken, and thank you.
Thank you, Dr. Gayatri. So those were really interesting cases because we usually think hypoplastic or aplastic nasal bone as a marker for Down syndrome and other chromosomal abnormalities, but in hypoplasia or complete non-visualization could also be seen in certain copy number variants. So this is a very important point because we know that there are guidelines at present which are saying that if there is a normal cell-free DNA result or even normal serum screen, and then if you visualize later on and the baby has, you're not able to see the nasal bone or it's small, then these guidelines in fact say that you probably may not do any intervention, or you could of course counsel the couple and also offer another option of intervention. So this is something, and but now we have all this data now, as we saw in your cases, and there are certain other studies also which are showing that yes, in around 5 to 7% cases of isolated hypoplastic or aplastic nasal bone, there may be copy number variants, that is, the micro deletions or duplications. And if there are associated abnormalities, then of course these will be even higher. And then, in fact, as you also mentioned, so there are two series where there were babies who did have single gene disorders also, which are picked up using whole exome. But these cases had other findings. So it was not like an isolated nasal bone abnormality. So, but still, it seems important that we should be thinking about doing invasive testing in all such cases and doing a microarray and not stopping with the serum screening or just a basic karyotype. So, but we of course have guidelines available. So I would like to ask, I mean, all the stalwarts here, Dr. Chinmay, Dr. Praveen, Khurana sir, like, what is your opinion or your experience? What should we be doing if there is an isolated nasal bone abnormalities? And would you want to do a NIPT, or would you want to modify the serum screening risk, or would you want to go for invasive? Like we geneticists would want to go for invasive testing because we have this available data available, and we who will have these small noses, flat noses. They're not all Down syndrome. There are so many other syndromes which present like this. So I would like to all of you to please let us know.
Okay, Shagun, if you permit me, I know it's
Yes,
concerned with genetics, but then I thought because there are a lot of people, a lot of confusion and a lot of questions regarding the nasal bone. First and foremost thing, I think in the first trimester, we need to be very specific that there is nothing like a hypoplastic nasal bone. It's either absent or present. That is as far as the first trimester is concerned. Second trimester, you call it as hypoplastic or absent. The problem is with the differentiation, it is really difficult to define nasal bone hypoplasia. So there are various criteria that have been postulated. One is the BPD nasal bone ratio, which is more than 10 or 11 is considered to be hypoplastic. Or the second one is the gestational age adjusted nasal bone length, which is less than 2.5 centile is considered to be hypoplastic. And there is a single cutoff method wherein you take 22.5 millimeters. Normally, when you see the nasal bone development, by about 19 weeks, it will be about 6.2 millimeters. And by about 22 weeks, it will be about 6.8. But again, in the Indian population, it is usually lesser in the sense we don't take the cutoff as 2.5, but we take the cutoff as 1.9. So the question is whether we do a karyotype or invasive testing or not. The Society of what do you call the maternal and fetal medicine actually said that in the first trimester, if you don't find the nasal bone, you get a NIPT done, and NIPT turns out to be normal. You just avoid any invasive testing, follow them carefully. But after Gayatri presenting so many micro deletions, copy number, I was really scared. And I think I would definitely ask for a chromosomal microarray, at least in order to can get along with the, what you call fish or QFPCR for the karyotyping. At the same time, I would like to ask for a CMA, chromosomal microarray for. So I think the approach is basically depending on the awareness of various copy number variants, which is associated with hypoplasia, that is facial dysmorphism as a feature of hypoplastic nasal. I think this is my approach.
I think I completely agree, sir. Once there is a hypoplastic or absent nasal bone, it has to be treated separately from just basic screening from Down syndrome. So we also have had the similar experience of finding a lot of these copy number variants because we offer at least a microarray. Once an invasive test is done, then a microarray is the other finding that they have. So in addition to aneuploidies in expected cases, we have found a lot of these copy number variants, and many of them have been classified as likely pathogenic. Now, the tricky bit for us as clinicians is, although we say that resource limitation is not something which we should consider, but the fact is the incidence of these hypoplastic and absent nasal bones are pretty high in our clinics. And we do offer microarray because sometimes there's consanguinity in the background. We tell them to store the DNA. That suppose the microarray comes normal, we'll go in for the next level of the genetic testing. Now, that is again, as information pours in, sometimes the troubles increase. So latest, I think today only we had a case where the microarray was normal, but now the whole exome sequencing has reported 2 autosomal dominant variations, which they have put as, uncertain significance, but something to do with Kabuki syndrome and somewhere else, which both have intellectual disability in the background. So that will just again end up in another round of counseling, and they have to then look at, the geneticist for the final answer, whether this entails. But unless we give that information, we are still stuck because there was a finding. The limit of the testing was to test up to the level of mutations. Now, if resources permit, do everything at the same time. If they don't, then we do it in a sequential manner, because most common thing we are expecting is a major aneuploidy, so QFPCR. Then we are expecting copy number variant, so we do microarray. And if that is also normal, then at least offer the whole exome sequencing.
Yeah, actually, when we have an isolated hypoplastic or an absent nasal bone, almost about 17.6% are associated with structural abnormalities like cardiac abnormalities, hydrocephalus, skeletal anomalies, facial clefts. So these are all the things that we have to. That's the reason I think the Society of Maternal and Fetal Medicine has suggested that a thorough structural evaluation.
So if a structural problem is associated with it, the counseling actually becomes easier. But it is the isolated, because if you see that the data, there was 6 to 7% in both the studies where they said with isolated hypoplastic or absent nasal bone, also there were copy number variants found. Yeah. So
this is a tricky clinical situation. Quite often, all of us are. We don't know whether to ask for.
And the problem is, by the time they come to us after confirming this, it is already some 22 weeks because they've been waiting since 12 weeks for the nasal bone to grow. So they come to the clinic at 22 weeks. And then even if we offer the test and they are convinced about the test, by the time we get the results, it's way past, reasonable time.
Do you also feel that there is some maybe there is some difference in ethnicity, like, because we don't have enough data from India at present? Because what I have seen,
ethnicity itself is very confusing nowadays.
No, that's true. But most of the times, in fact, many of the cases which I have seen, if you look at the parents, one of the parent would be having a small nose. And in fact, for me, whatever cases of nasal bone abnormalities, I have done a procedure. If it is isolated, there is nothing else. Everything turns out to be normal.
We have found many.
No, I'm sure there are, of course, like Gayatri has shown and you are saying, and of course, literature is there. But I have just, whatever I have seen, and I've seen that, one of the parent would be having a small nose and all, and probably that is just a familial variant. So that is also one thing which we can keep at the back of our mind, that, if there is nothing.
Sometimes, yes, but then again, nasal bone absence, the contour might still be normal.
Exactly.
Yeah, absolutely,
Exactly.
absolutely. So I mean, what I practice is that I always do invasive and I always do microarray. But if it is normal, then at least I kind of reassure them, and especially if one of the parent has a slightly small nose, I kind of take that also in my counseling and tell them that the microarray, I mean, looks normal, baby looks otherwise normal. Probably this is just a familial kind of finding for you, for your family, something which is for just specific to your family and not a pathology.
Hope the
If it
parents
is
doesn't get
isolated and
offended.
one's array is normal.
No, sir. See, even this can be tricky now because we have a lot of donor conceptions. We have mixed genetics. We have mixed ethnicity. We have different, generations with different ethnicity. So I don't know. I just deal with the fetus individually.
No, I think that is the safest method is to, when once you find a positive feature, I think you need to evaluate. And to the extent which you can, because there is no shortcuts to it. Because I think that is the most important message that we need to convey. Because whenever you have a hypoplastic nasal bone or an absent nasal bone, I think those are the fetuses that have to be evaluated or investigated further before you label them as isolated and insignificant or a simple dysmorphism of the face.
Yes. So, I mean, we should be at least doing a microarray for all these cases. But whether we should do exome or not, I don't think we have enough data as of now. So,
Will you
whatever
reassure our
good
patient? Will you reassure my patient who has had a hypoplastic nasal bone with a normal microarray? If she comes to you at 23 weeks and says, Madam, should I do anything else? Will you reassure and say it's
I
okay?
will reassure, but I will keep
Dr.
her on
Ashwin, will you
follow-up.
reassure? All the geneticists sitting here tell you we will reassure, we will stop doing everything else.
I would like to follow up the patient. That's one thing, because sometimes this
Follow
is
up till when? Follow up till when?
with serial biometry till third trimester. Because
Then what will
sometimes
happen? Suppose it doesn't grow. Suppose third trimester she has
no, it's
less
not for the
growth.
nasal bone.
Suppose
No,
she might have mild polyhydramnios because her sugars are abnormal, and then what do you do?
No. I'm saying I would follow her up for serial biometry, because sometimes this could be a feature of a skeletal dysplasia, which would manifest later in pregnancy. So that for that
No, I
purpose,
think Shagun, I think this that doesn't matter in the sense. See, there is no question of follow up because the patient and the couple ask you a direct question: is my baby normal? Can you assure me? Do you want me to continue the pregnancy? That is a very tricky situation. That is one place where we have to be very careful in the sense. We are responsible for it. So I think it is better you investigate to the extent you can. You offer. Whether they get it done or they don't get it done is a different story.
Dr. Ashwin, you would want to say something different?
Yeah. So there's no end to what you can offer. See, even an exome is not enough. Ideally, you should do a trio exome, because otherwise you end up getting those VOUS. So there's no limit to that. And as you all said, as at the end of that also, you cannot say, I guarantee you a normal baby. There are so many unknowns there.
So there will be many people in the audience who must be thinking that once you see an absent nasal bone like increased NT, why not terminate the pregnancy there only?
No.
That is true for any finding, right? Because as we say, there's no end to investigating. And again, like as you mentioned in that case, finally you may end up with a VOUS, despite doing everything. Now, what would you tell the patient? So it's all we have to kind of.
But the reason we should not ever decide to terminate a pregnancy because we don't have an answer is because if you don't have an answer, you don't have any way of moving forward. So it is important that you work up this patient. Even if you're deciding to terminate, also do all the tests so that you have an answer towards the future. So please, a humble request to everybody who's dealing with patients with these kind of questions and queries. Termination of pregnancy might be just your solution for a headache for the next few months or years. If she comes back with a second pregnancy with absent nasal bone, and then you start looking like Dr. Shagun at the face and think, oh, the mother also has a small nasal bone, and then you start worrying about it, it's a lot of time and effort lost. So under all circumstances, we should remain clinicians and offer all the tests as logically said. Like Dr. Ashwin said, to the extent that can be evaluated, to the extent that can be answered. And that is our limitation. So we have to accept that.
And that should be accompanied by a proper counseling of the patient.
Counseling.
So we are offering all these tests. We have to do a pre-test counseling and explain about the possibilities of getting CNVs or even other variants of uncertain significance, where despite doing all this, we may not have an answer to give yet again.
Shall
But
we
at
move on?
least yes. So I think we can probably move on to the third scenario now. So again, this involves the nose only, but it's a more severe abnormality. So Dr. Neelam.
I think there are a lot of audience questions. I don't know if Khurana sir would think that we can just do this scenario and then the audience interaction and do the rest of them as another session.
I think
so, because it's getting too much delayed, but then these are problems that have
No,
to
so
be
we'll do this binder
we
faces
do
thing.
this first section today, and
Yes, sir.
then our second part on orofacial clefts, micrognathia, and the miscellaneous we'll do next time, because that'll give us enough time for justification.
Because Dr. Shagun has really worked it up in detail. So I think it should get enough time for discussion.
So we'll do the first half today, and we'll do the second half next month.
Next time.
Yeah.
Go ahead. I think Dr. Neelam.
Yes, sir. Sir, I have joined from my iPad, but I'm not able to unmute that. Sir,
Dr. Neelam, you just stop the microphone, the speaker of your laptop, and then you speak into your iPad. There is an echo.
iPad, I'm not able to unmute.
I think it is probably the connectivity. It's not the speaker or anything.
Are you connected with two devices, Dr. Neelam?
Just want to unmute from iPad.
We have a trade partner video to do before we move on to the next session. Should we do that?
Yes,
now?
ma'am. Now it's done.
Okay.
Yeah.
My voice is better, sir, now?
Yes, yes.
Definitely,
much better,
definitely
yeah.
better.
Go on.
Very good.
Great.
Yes, sir. Yes, sir. Now we will move on to the third part of this upper face anomalies. So this is binder faces, and in this, so this is first family. Here we see this is a non-consanguineous couple, and this is a second pregnancy of this non-consanguineous couple. Mother age was 40 years. They had one 14-year-old girl baby. She was fine and developmentally and everything was okay. And this second pregnancy was also conceived spontaneously. In that, triple marker test was done in early second trimester. That was suggestive of intermediate risk for trisomy 21. And antenatal USG at 20 weeks suggested flat face and echogenic intracardiac foci. And with the findings of these in scan and this maternal age being 40 years, we decided to go with amniocentesis, and amniocentesis was done. And here we can see the binder faces. So this flat face we can see. And then amniotic fluid DNA microarray was advised, and that suggested trisomy 21. So this was the first case in which antenatally scan detected flat face, and then DNA testing suggested trisomy 21. So this is our second family. Here the 5th degree consanguineous couple. They had, this was the third pregnancy. In the first pregnancy, the baby, there is significant evidence of perinatal asphyxia. There was meconium stent liquor and there was no cry at birth. All antenatal USGs were told to be normal, and baby died immediately after birth. In the second pregnancy, there is query history of sudden infant death syndrome at 3 months of age. And this was the third pregnancy when they presented to us. In this scan was suggestive of flat concave face and then flat nasal bridge with abnormal angulation of nasal bone. They were, the nasal bone measurement was 6.3 mm, that is less than 50th centile for Caucasian population, but no Indian standards are available at this gestation. And then in the further skeletal survey, the femur length was -3 standard deviation with mild bowing and distal femur. Tibia length was around at 10th centile, and other long bones measurements were around 50th centile. Amniotic fluid liquor was a little higher side, 24 centimeter. And there was subjectively narrow thorax that we can see here in the first ultrasound pic. and there was bell-shaped thorax, and the ribs were wavy, and then bone density was normal, and there was no epiphyseal stippling. So all these features putting together were suggestive of skeletal dysplasia, but the family did not decide for further follow-up, and they did not go any genetic evaluation further. But diagnosis was with findings and also decided that was suggestive of skeletal dysplasia. So this was the second case presented in late advanced gestation, around 28-29 weeks of gestation. So this is third family. Here this is non-consanguineous couple and the first pregnancy. Antenatal ultrasound was done outside, and that suggested binder faces, fused sacral spine, doubtful small stomach, intracardiac echogenic focus, and within the left ventricle. And they came to us with the ultrasound findings, and pregnancy was terminated, and they came for fetal autopsy. Fetal autopsy also confirmed these findings, and here we can see in the first image the flat concave face, flat nasal bridge, and this flat nasal tip suggestive of binder faces. And in hands and feet, there was brachytelephalangy. Brachytelephalangy means small and broad distal phalanges, and the fetus was male. So as a routine part of our fetal autopsy evaluation, we do fetal x-rays for all the fetuses. So in fetal x-rays, there were epiphyseal stippling of upper ends of long bones, and that we can see here. At the upper end of femur, and here we can see the epiphyseal stippling. And the vertebra also we can see in the lumbar part very clearly epiphyseal stippling. And then the tarsal bone, here the ankle joint is also having epiphyseal stippling. So all those features putting together are suggestive of diagnosis of chondrodysplasia punctata, that is brachytelephalangic type, and this is an X-linked condition, and the fetus was also male. So in this, as a routine, first we do common chromosomal aneuploidy screening. Multiplex ligation dependent probe amplification was done to rule out chromosomal anomalies in chromosome 13, 18, and 21 from the fetal DNA, and that was normal. Exome sequencing from the fetal DNA was also done, and that was negative. Then detailed history was taken again, and there was history of maternal connective tissue disorder, that is systemic lupus erythematosus. So final diagnosis for this baby was established. We put as chondrodysplasia punctata associated with maternal systemic lupus erythematosus. So now this is fourth family. Here, this is the third degree consanguineous couple with first pregnancy. They presented at 18 weeks of gestation with antenatal ultrasound suggestive of binder faces. So here we can see the flat face and short nose. And then here there was vertebral stippling. And amniocentesis was done. Amniotic fluid DNA microarray was normal. Then again the detailed phase, the history was taken, and then we found in the maternal side, the mother and multiple relatives had the same facial profile. So all had those flat face, short stature, flat nasal tip, and flat nasal bridge. Then family counseled regarding possibility of binder faces as benign familial variant, and they decided to continue the pregnancy. Then pregnancy continued, and the female baby was delivered, and she is now 2.5-year-old with her developmental milestones are normal. Then probe examination we did at 2.5 years of age. She is also having the same, the findings were noted in antenatal ultrasound. Concave facial profile with relatively frontal bossing and small flat nose. So final diagnosis for this baby was established as binder faces as benign familial variant. So we have discussed 4 cases.
Yeah, so thank you, Dr. Neelam. So binder faces basically is not a diagnosis. So as we can see here through these 4 cases also, so all 4 had some different kind of etiology, underlying etiology. And in fact, in the last case, this was just a normal benign familial variant with no other morbidity in any of the family members. So this is the actual kind of the technical definition of the binder faces. But then again, as I said, this is basically a phenotype and not a single diagnosis. Next slide. And there can be various causes, as we saw through these 4 cases. So one of the commonest cause, of course, that it could be Down syndrome, and then it could also be part of various skeletal dysplasias, of which the most common one, which presents like this antenatally, is the brachytelephalangeal chondrodysplasia punctata, which is an X-linked recessive condition. So it presents in male fetuses, and in fact, this is what we had suspected in the third case in that particular fetus, but then on exome sequencing, there was no mutation in that particular case. So this is one of the commonest skeletal dysplasia, which presents with this kind of facial appearance, and the epiphyseal stippling and all often can be seen antenatally, but sometimes it may be a little tricky to pick those up. And often the bone shortening and all would come much later in pregnancy. So you would not really see it in the second trimester scan. So again, the importance here is of suspecting it and doing the correct test, which is exome sequencing, to pick up this particular condition. And then there are certain other skeletal dysplasias like Stickler syndrome, Cutel syndrome, which have a more severe postnatal phenotype, which can also present with binder facies. And then, of course, the maternal history here becomes important, because warfarin embryopathy can also present with the similar findings. Various maternal illnesses, like we saw in that third case, finally it was because of SLE that the baby was affected. Even hyperemesis is known to result in maternal vitamin K deficiency, again presenting in a similar fetal finding. And of course, as we saw in the last case, sometimes it may just be a benign familial variant, but this we can come to know once. One thing, of course, in that particular case, we saw the whole family and we investigated later also. But otherwise, if you don't have such a history, you could again do all the investigations like microarray, exome, and if everything is negative and otherwise the baby looks fine, then we could label it as probably a benign finding. So here, basically, most of these cases would kind of the ones which don't have any significant abnormality like a skeletal dysplasia or of course Down syndrome and all, they do improve postnatally. And I think now I would probably ask Dr. Parvati whether she can tell us about what is the postnatal outcome of these babies, and do they require surgery or do they improve with time? And like, are there any neonatal complications which we should be counseling the patient once we detect it on scan?
Thanks, Dr. Shagun. Basically, I am at the other end of the spectrum. I'm a reconstructive surgeon. Most of the patients, I'll be counseling the patient himself, not the parents. That is the difference. So basically, the patient comes to us about adolescent age, or when the skeletal maturity is almost finished. That is the picture what we usually see. But neonatal period, most of the times, this isolated binders syndrome, yes, kind of children, I don't think there is much complications like breathing or feeding. Very occasionally they may have, but that is, it depends on the severity. Basically, it is nasomaxillary hypoplasia, wherein there can be breathing difficulty and feeding difficulty, but usually they will improve. Usually they don't need any intervention at that time. But an adolescent, before the bone growth picks up, probably they can be helped with orthodontist, wherein they can add braces for the malocclusion and sometimes face masks. And once they go into pubertal pickup in the skeletal growth, that time we don't intervene. And finally, again, after the skeletal maturity, probably intervene to do the nasal reconstruction as well as correct the maxillary hypoplasia. What we do is, for the maxillary hypoplasia, we use most of the reconstruction is basically nowadays it is done by the cartilage, using the cartilage, costal cartilage. Premaxillary augmentation, perialar augmentation for the improvement of maxilla, and dorsal augmentation and coral malar lengthening for the nasal correction. That is one type of correction. The other type of correction, where it is very severe, probably they need osteotomies, wherein whole maxilla is moved forward. That gives a better result, but that is preferred in more severe forms of cases. Beyond that, they don't need much of intervention.
So
I don't know whether I could
primarily
add
the
something in this.
cases like
No,
no,
no.
definitely. So I think probably yes. So the cases where we don't have any other underlying genetic cause, probably
Yeah,
this just is primarily a cosmetic concern,
correct.
which most of the time would require surgery at a later age.
Correct.
And so very rarely, probably some neonatal issues may be there. So, but most of the time, and does it improve with age? Like, have you had any?
No, I don't think it improves with age. It is an intrinsic factor, basically the growth of maxilla and antenasal spine, all those areas where the bone is supposed to grow, it is hypoplastic and the growth is definitely deficient. I don't think it is,
Any
it
age
improves
dependent?
automatically.
Okay. So most patients who would have would have
Your voice is not clear.
basically cosmetic concerns, and that also could be handled usually around yeah, concern. So once we have ruled out the more ominous etiologies, so we can counsel these families that it's
Yeah,
primarily going to be a cosmetic issue, which would be amenable to surgery subsequently.
yeah, exactly.
Praveen sir, anything sir you would like to add? I mean, are there any cases where there is very severe, any antenatal abnormalities where it suggests that very severe airway involvement is there, where we should
No,
counsel the families for some neonatal interventions?
no, as you have already stated, it is a phenotype where we have a typical presentation where there is a flat face. When you take the facial profile, you very clearly delineate that there is a absent or hypoplastic nasal bone, flat facial, there is nasomaxillary hypoplasia. Along with it, there is a depressed nasal bone, alar prominence and all. I mean, see, basically what we are dealing with is very rarely they can be associated with breathing or swallowing, but then quite often, as Dr. Parvati has stated, that they improve over a period of time. So there is no need for any intervention. That's what I realize. And another thing is, this is basically when we have cases which are sporadic or familial, then only we need to think in terms of some interventions. Whereas suppose if it is a chondrodysplasia punctata, where you do get certain specific features like vertebral abnormality, stippling of the epiphysis of the long bones, shortening of the long bones, there is nothing much that can be offered. And then associated with SLE and vitamin K deficiency, these are all the things that we have to keep in mind. But if it is familial, yes, definitely we need to follow them up. And then as they become adolescent, they become more conscious about their facial appearances. Probably that's when Dr. Parvati can help them regarding the cosmetic appearances and all. And that's what I feel.
No, sometimes when the nasal bridge is very, very depressed, there is definitely a possibility of compromise of the upper airway. That literature suggested this. We had one case where it was very, very flat on the antenatal ultrasound. We were not able to see the nostrils also. But, after the baby was born, the literature says you should put in nasal prongs to keep the upper airway patent. Now, our neonatologist just, he put a steri strip by pulling up the forehead of the baby a little bit. And in 2-3 days time, what he said was the cartilage also becomes a little thicker. Once it comes out, it becomes a little sort of, it dries and it hardens itself a little bit. And that itself helped in maintaining that patent airway. We didn't have to constantly put prongs there. But after a few days, the baby was breathing easily and that was better. Correction, as Dr. Parvati said, will only happen after complete skeletal maturation. I don't think we've had any need of any kind of intervention to keep the upper airway patent because of severe binders as such. Some of them had polyhydramnios in the 3rd trimester, and we had a follow-up of almost 55 cases. So few of them had Down syndrome and other genetic abnormalities.
Expected because of the probably swallowing problem.
Probably, sir. Yeah, because those are the ones which had bad outcomes, but the others, they have done so quite well so far.
So then once we see this abnormality, so after the thorough workup, once we have ruled out all the genetic etiologies and all, then we can basically, depending on the severity of the phenotype, probably the more severe cases, we can be more careful in the neonatal period regarding breathing issues and all. And the rest probably we can reassure, and then subsequently they can follow up regarding, depending on their cosmetic concern, probably they could just follow up with a reconstructive surgeon. I think
But
that's
one question to everyone, particularly Chinmay as well as Ashok and Bimal. When you are counseling these patients, I feel it is very, very tricky and little difficult to counsel them, because the first question they ask is it a boy or a girl? That becomes a big problem, because if it is a Binder's faces, and then if it is a girl, I mean, definitely, I think the family are very, very, have a lot of reservations. And another thing is that how far the face will develop as the child grows. These two questions are quite often asked whenever we come across and when we try to counsel these patients. So what is your experience regarding this, and how do you answer them? Because I can use them.
Yeah, the girl boy issue is sorted out by the PNDT disclaimer, so that we have to absolve ourselves of that thing altogether. The other thing is, we use pictures like just what Dr. Shagun showed here. We do a 3D reconstruction of the face and show them what this fetus is looking like. And for
they
future,
we use with the 3D. They get horrified. I'm telling you genuinely.
No, sir. It actually sometimes helps, because they just see that it is like that. You turn it sideways, show them the contour is like this. And sir, what I do is I use my previous patients' photographs, because we now have a follow-up of good about 55 cases. And at least 30 of them have had very good outcome. And those mothers are sending us pictures every year. So we have certain follow-ups for about 5-6 years where, the children are growing normally and they're looking fine. Of course, the severity varies in different people, but in mild cases, it's not that bad, and not everybody. I don't know if Dr. Parvati will disagree, but I don't think all of them come for reconstruction.
Yeah, and pediatric age group, probably they look cute and things like that. Probably that camouflages their deficiencies and all those things. Once they pick up the skeletal growth, probably it becomes more apparent.
Yeah.
Adolescent age, where the mandible becomes dominant. In that time, it becomes more.
For us, the tricky bit is when we see epiphyseal stippling with binders, what to offer, because this genetic testing we've offered in many cases and it has come back as completely normal.
Yes.
Some people have decided not to continue because they feared a short stature and all this, but we've never had a clear way of counseling these patients. So we tell them the outcome is uncertain. Those who are up to the challenge, they take it.
Yeah, the problem comes only when it is an isolated, when it is associated with some genetic abnormality or a condor dysplasia punctata. Positively, your counseling will become guarded.
Sir, I would little bit add here. Actually, not all the genetic skeletal dysplasias would have the same degree of severity postnatally. Like, in fact, many of these X-linked type of chondrodysplasia punctatas, they do not actually have that much degree of shorts. And as adults, their height is just like low normal. They are not even short stature. So, in fact, the only concern remains the face eventually.
No. It's not that question of stippling and shortness. It is associated with other vertebral body abnormalities.
Yes, sir. So there are some cases, some skeletal dysplasia, sir. So especially that I had shown the differential, so that Cutel syndrome. So that is in fact one of the condition which closely mimics the X-linked chondrodysplasia punctata, and they will have this laryngeal stippling, laryngeal calcification, cervical cord abnormalities and all, and they can in fact have very severe outcome. So I think that's the point whereby, that's again to reiterate that we should do genetic testing, because then only we can distinguish amongst even these different genetic types and prognosticate them accordingly, irrespective of our scan findings.
Once you do a genetic testing and prove that there is a genetic association, the counseling becomes much more easier.
Easy.
Yes, sir. Yes, absolutely.
So Ashok, what is your go?
It's a question of the parents being strong enough to accept the dysmorphology. If the parents are able to bring up the child to believe that it just doesn't matter, it works because a lot of these will evolve provided we've excluded the warfarin embryopathies in that particular group. So it's really a question of psychology. There's no question of telling them the sex, of course, and the fact that we cannot predict how severe it's going to be. And if they're not going to be able to bring up the child properly, then so be it. Then it is their decision.
Yeah,
but I think this gallery of patients with which to show them and to show how some look completely normal, particularly from the frontal aspect, is really very useful. The most gross aspect is from the side aspect. And but a frontal picture is very encouraging.
You are not going to diagnose a Binders by frontal, isn't it? You have to do a frontal.
No, I'm talking about to guide them.
Later, sir, later, how will they look?
So it's a question of telling them that, look, now this is a 12-year-old and it's almost normal. And you could have an accident and look exactly like this. So why not just get it fixed later on in case it needs fixing? Unfortunately, our Indian mindset doesn't work like that. And therefore, you have to take that into perspective and leave the final choice to them. The fact is, it's not a lethal abnormality. The fact is that a lot of us in society are so-called, in our concept, not so good looking. But the fact is that we all survive. And there is place for everyone on the planet. Because our social aspects are so gross and so inappropriate, we then have to counsel differently and say, look, are you ready for this? But otherwise, classically speaking, it should really not come up because, just like you have cute faces, you don't have such cute faces, and they all should be acceptable to everyone in society.
What Bimal, what do you say? Is Bimal there?
I think he got poor connectivity and therefore he's gone off.
Oh, okay. Anyway, thank you.
Yeah.
It was wonderful.
Thank you. And we have a lot of questions.
A lot of questions, yes, sir.
Yeah. Please go ahead.
And if I can get the ball rolling with the very first one, the rest are all nasal bone. But there's this very, very important question. I know it's been answered, but if you could please tell us again on how best the brain is preserved for further processing. And so if we could have this from our genetics and autopsy departments, if we could have the answer, please, to make sure that we do not end up with a with brain that gets completely autolyzed. What's the best way to preserve it?
So the two best ways. One is
can someone unshare this screen?
If it's possible, we could dissect the brain fresh. So immediately after delivery, if it's possible, that's one of the ways whereby the brain would be really be no autolysis. Otherwise, what we do and what I would request all the obstetric colleagues to do is that as soon as the baby delivers, just inject 5 ml of formalin into the baby's brain through the anterior fontanelle if it's a small baby, and if it's a bigger baby, then you can inject up to 10 ml of formalin. So once that is injected right at birth, the brain would get fixed. And it's best not to dissect the brain after this till around 1 month. So once if you're not able to do it fresh, then put the formalin and leave it for 1 month. After 1 month, the brain would be nicely fixed, and then we can get the proper sections and all.
Yeah.
Where exactly is the tip of the needle kept? Through the anterior frontal?
Yes, sir. Through the
into the
anterior.
ventricle or what?
No, it's basically just
the
in the center. So we just go directly vertically into the anterior fontanelle. So it is basically somewhere in the subarachnoid space kind of a thing you're entering. So then the formalin spreads around the brain and it diffuses through the cerebrum.
So subarachnoid space. Subarachnoid space. Yes.
And then there is this question which we can take further with Dr. Ashwin Dalal on in recurrent holoprosencephaly, where karyotyping is normal, should we be doing exome sequencing?
Yeah, so we already discussed about that, that when karyotype is, so we have this options of karyotype, microarray and exome, and each one gives a different kind of information. So ideal would be to do all these three if that condition is known to cause disease by way of deletion, duplication, as well as single gene disorder, as well as chromosomal abnormality. And the classical example is holoprosencephaly, where all three kind of abnormalities are known. So ideally, you would be expected to do all three. Whether you do all three at a time or successively will probably depend on the economy of the patient, as well as how late they have come in pregnancy. Yeah, ideally something, how much you can reach there is up to each patient.
Yeah, which also answers our next question from Dr. Indrani Das. To combine karyotype and CMA is purely a question of economics, and some people want an answer faster. Now, the next question is measurements. Just to clarify, Dr. T. N. Praveen, do we measure the nasal bone in the first trimester?
First trimester, you don't need to measure because you are not talking about hypoplasia at all. You are saying present or absent.
And in the second trimester?
I mean, quite often it is subjective. But
Yes.
then when you need to be very specific, yes, you may take certain parameters into consideration like BPD nasal bone ratio or gestational age dependent adjusted nasal bone. But then quite often we don't do that. I mean, it is very obvious.
Yes.
There is one small tip that suppose if the nasal bone is of normal size and it is not hypoplastic, usually you see the skin echogenicity line, they become very, very parallel. And the tip reaches up to the end of the echogenic line, which is superficial. That itself gives you that the nasal bone is normal sized, isn't it? That's what we always follow.
Yes. Now, so that answers some of the questions that we had from Shilpi Jain and S. Malini. But the other question is one side versus both side, unilateral versus non-unilateral. Is a unilateral absence or hyperplasia as significant?
It is significant. It is significant, and then we need to investigate them. There is no second thought about it.
And
but then, how often are we going to do the? I mean, you call it as a, premaxillary triangle and see for the bilateral nasal bones. So quite often, when you find one nasal bone which is normal sized, you just take it for granted. Rarely you really do a premaxillary triangle look for the both the nasal bones. What is your idea?
Even on 2D, you can just rock the transducer.
Yeah,
there is a lot of conflicting literature on the famous one hypoplastic and the other one not hypoplastic in the fetal medicine literature. It does not exist in the radiology literature. What has been your experience? Have you ever been let down by the fact that you did not investigate a unilateral absence?
No, till now, no. Hopefully not in future.
Her experience,
No, so we treat hypoplastic and absent as one and the same. So our counseling is unilateral is considered as hypoplastic, sir.
Absolutely. So this is very clear that in the first trimester, it is absent or not absent. In the second trimester, it is hypoplastic, whether it is unilateral or bilateral. The next step is the nomograms to be used for measuring the nasal bone. That's from Dr. Kalpana Lekala. And what would be the answer to that? Which nomogram should we use?
If we look at literature, we get it. Indian data has been published by Narayani et al. That's also updated in the perinatology.com site.
Yes.
So if you look up there, you get a fair chart for every gestational age. What we have done is you've just taken a printout of that and put it so that you don't have to every time look up there. So you know what's the 5th and the 90th centile at every gestation.
Yeah, but good old perinatology.com can be depended on.
Absolutely.
All the time, yes. And then, of course, we need to develop an algorithm to straighten out our nasal bones because of our ethnicity. And I think for this, we must get a task force in our SFM community to do this. And I would request Dr. Chinmay to lead that, within 3 weeks, let's have an answer. The question is, yes, where would we suggest only an NIPT in the first trimester, or should we counsel and let them decide non-invasive versus invasive? And in the second trimester, non-invasive versus invasive for isolated versus not isolated. So we really would need to do that because currently we are a little confused. There is no doubt that the syndromes are so rare where you have a nasal bone absence that you really wonder whether it's worth it doing a invasive procedure. The fact is that also that if you do an invasive procedure and miss out on some part of the investigation, that means you would only do a karyotype or a qFPCR and forget about the microarray, then that would also be incorrect. So we need to develop this and we will then publish it accordingly, because we could make out from our discussions in the beginning that we didn't have any clear answers on this particular thing. Yes, we could wait and see because it's more reliable in the second trimester. What does the panel think? Suppose we were to see something the first trimester, a doubtful nasal bone, absent nasal bone, and it was the only finding, and everything else was fine, and the biochemistry was fine. And even say, then the question is, do I do invasive testing first trimester, or do I do NIPT, or do I just wait till 16?
NIPT.
Wait till 16.
16 weeks.
Would also like to
And
wait,
Dr.
sir.
Ashwin, what would you suggest? Should we just wait till 16 weeks and see if it comes as an isolated finding?
You are asking me?
Yeah.
No, I'm asking Ashwin. Yeah.
Oh,
I really don't have much, but
Okay.
as you said, I really feel doing an invasive procedure and then doing only karyotype would not be a proper thing. If you're doing invasive, then please
That's
go
very
the
sure.
all
Once
the
we
way.
do invasive, we will do everything. Shagun, would you agree with that? That once we do invasive,
Yes.
we do everything. The
Yes.
question is non-invasive versus invasive, and would we wait till 16 weeks? So let's go through all the data put together. Let's do a meta-analysis on what we have from our part of the world and get a guideline, because we do need this. After all, our patient is going to say, look, I have a fibroid, I've had one miscarriage before. Technically speaking, it does not stop us from doing an invasive. But then to counsel her, we would say, okay, the guidelines are we should be doing invasive, or the guidelines are that let's do non-invasive and then see. And then, of course, we offer it to her on a platter as always. So I think for that, we would, in one of our meetings coming up in the next 1 or 2 months, we'll have an answer for everyone. So that then we follow that algorithm, we have a set algorithm, and nobody can catch us for not completing that algorithm. And therefore, we will then add all of this. So moving on, there's a question from Dr. Rashmi for everyone. And I don't know how much this is connected to this, but it's a genetics question. If one boy child is died of Duchenne muscular dystrophy and has a normal girl child, and she has a normal girl child, what prenatal test to advise to couple planning to have another child? So I guess that's for DMD. So we will skip that question for want of time. The one question that we do need to answer, and that is the perspective of how frequently, and this is from Dr. Ghazala, how common is chondrodysplasia punctata in association with SLE, and what's the recurrence in these cases of maternal immune disorders? So we have chondrodysplasia punctata. What would be the incidence of SLE? And then in that patient of SLE, what's the chance of recurrence?
No, it is not the question of SLE and chondrodysplasia punctata. Chondrodysplasia punctata is usually with vitamin D deficiency. Vitamin K deficiency. And SLE is associated with binders. But then chondrodysplasia punctata associated with SLE, yeah, there are reports, but then it's not that common an association.
That's right. Now, the other.
What do you say, Shagun or Ashwin?
Sir, from what I have reviewed in literature, I think, I mean, SLE as a cause of chondrodysplasia punctata or binder is a rare scenario. But the women who have SLE and who had one baby with binders or chondrodysplasia punctata, then the recurrence risk is pretty high. There is some unknown antibodies in these women which have not been actually characterized, which are kind of, they somehow lead to this phenotype in the baby. And then this recurrence risk in that particular lady who has that unknown antibody is pretty high actually.
Could it be because of 4P mutation?
No, I am not aware of that.
Ashwin, reports on that. And then there's a question from Dr. Shashikala on the dose of vitamin K. What are the preparations available?
Pardon me?
Administration of vitamin K, would it reverse the situation? And what are the doses available?
No, I think Chinmay, you should tell. We don't know.
No, sir, I don't think it works like that. It is like vitamin K deficiency in the period of organogenesis when
That
this
is actually
important.
6 to 7 weeks. That's what they say.
So when women have hyperemesis and a history of, completely no proper nutrition intake in first trimester, these things can be seen, but it's not that you have to replenish them with vitamin K
Supplement.
here.
Right.
So just regular multivitamins are fine.
Which brings us to the end of all the questions, and I think it's been a very exciting session. So back to our hosts for closing.
And we've got confirmation from Dr. Parvati also that she'll be there in the, because that cleft session will be really good, because the cleft correction, the amount of, practical experience the people from the NIMS group have is something which we should take advantage of. And that's one area where prenatal diagnosis and counseling and a confidence from the caregiver point of view that things will be taken care of, some financial help from the government, everything has come together to give us a very good outcome of a correctable fetal anomaly. So we have, I think everything has really been very enlightening. We didn't realize how we spent time, and Dr. Shagun has put together very, very clinically relevant cases and brought together all the experts to discuss this. So thank you very much, Dr. Shagun, for, orchestrating this thing. And like part 1, we did not stay with Bahubali 1, we want the Bahubali 2. So
Now we have
Now
Bahubali
we'll
3.
have Bahubali 3 coming up.
Yeah, actually,
Sure,
the
who
moment
knows?
Shagun shared her this thing proceedings, I asked her for only one question: will the time be sufficient?
Because you know it all. If we're talking about Bahubali, will be in the category of Rajamouli, isn't it? So thank you very much, Khurana sir, Praveen sir, Dr. Bimal, everyone for encouraging us to keep this going. Thank you, Dr. Shagun, for taking this together. I think it's Dr. Shagun's job to give the vote of thanks now. So let her do it. But unofficially, I'm thanking Dr. Ashwin and all our delegates here. And a great job by Dr. Neelam and Dr. Gayatri. Dr. Shagun, you can close.
I think, so thanks a lot again, SFM and Khurana sir, Praveen sir, Dr. Chinmay. It was wonderful for me to organize this, and I mean, we are going to, of course, have our Bahubali 3. So thank you everybody for participating, the presenters, Dr. Neelam, Dr. Gayatri, all our panelists, Dr. Khurana, Dr. Praveen, Dr. Ashwin, Dr. Chinmay, Dr. Parvati, and our ceremony master, Dr. Rupa Darshini, whom I can't see anymore now.
No,
And,
she's there.
She's there. Okay. And very much thanks to Vishal, who is always there at the back end and who keeps things moving smoothly all the time, and this never forgets to remind, to send timely emails and organize everything so effortlessly. So, and finally, of course, thanks to all the trade partners who make these events possible. So I think we can probably sign up for the day and await the next session. Is there any final words, Khurana sir?
Well, I'm really fascinated by the fact that we've taken one single topic on the face so far, but we do understand from today's discussion that this is extremely relevant. After all, the face is the first thing to strike the parents whenever a baby is born. It can be devastating, and it can also lead to a lot of litigation, and we need to get ourselves out of this. So to have divided this into 3, I think, was a fantastic idea, and we might need to divide it into a 4 as we go along, but it's working well for now. And thank you so much for this concept, and it's been great, a really great evening of learning today.
Yeah, thank you.
Thank you, sir. Thank you, everyone.
Thank
A very
you.
good evening.
Good night.
Good night.
Thank you and good night.
Thank you, Dr. Shagun and